the end to show the use of Epstein-Barr virus targeted in monitoring. Okay. May I have my slides, please? Okay, the topic that I was given actually is the surgical salvage for recurrent nasopharyngeal cancer and also the monitor. Next slide. I have only 3 slides. The first slide is if we have a small tumor, when the tumor is located in the posterior wall of the nasopharynx on the roof, then we split the palate and implant brachytherapy as a gold-grain implant. And if the tumor is small, well-localized, and accessible site, this can be done with very good results. Nearly 85% local control results can be achieved. When a localized tumor, but it's not at a good site, usually the tumor is on the lateral wall in the recess. But when it's not involving the skull base or involving the carotid artery, then I have been carrying out resection with the maxillary swing approach, try to remove all the tumors. And I only do this when I think I can do a curative resection. I don't do salvage resections. Next slide. The results over the years, 89 to 2006, I've performed 200, I hope 2,000, but 212 patients. I started off all to be curative resections, but at the time of the exploration, 48, roughly 20% of them, there were still tumor cells left behind on the clivus or sometimes on the carotid artery. All these patients, so therefore the curative resection is only about 164, 48 were palliative resections. They all survived the hospital. The morbidity nowadays is mostly trismus. Initially, I had about 20% palatal fistula, but in the last 3 years, we have modified the palatal incisions. Therefore, we have eliminated the palatal fistulation with the maxillary swing approach. So we don't have any more fistula. They have certain degree of trismus because of radiation and the resection of the pterygoid muscles. With a median follow-up of 2.5 years, with this resection for selected group tumors, 5-year actuarial tumor control is roughly about 67%, 2/3, and the 5-year survival, disease-free survival is about 52%, 50%. So for selected patients with localized tumors, if it's resectable, then you still have a 50% chance of being salvaged. The carotid artery infiltration is one of the independent factors affecting the survival. In recent years, I'm getting a little bit more aggressive, so when the tumor is on the internal carotid artery, I try to peel it off, but then the carotid artery has a chance of blowing out because of the desiccation. So I put a microvascular free flap, usually a rectus muscle flap inside, and join it with the facial artery on the side, and then hopefully to give further radiation. But that's only a handful of patients. You have to really discuss with the patient whether they would like to undergo this kind of quite major resections and reconstructions. And still, there's no guarantee that we can cure these patients. Next slide, last slide. As for the detection of recurrences, patients had radiation, chemoradiation. The follow-up is still basically clinical endoscopic examination, and if something suspicious, we do a biopsy. The CT scan will tell us soft tissue enlargement, bone erosions. The MRI will show irregular tissue. When it's progressively irregular or getting bigger, then it becomes suspicious. The PET scan actually depends on the critical tumor volume. When the tumor volume reaches a certain size, then it's hot. Really small tumors, which could be resected with surgery, sometimes the PET may not be really positive. I'm doing a study on this, try to test it. But actually, with the Epstein-Barr virus DNA follow-up, we test these patients. Some of them, the report was that the DNA virus level could be increased even before clinically you can see the tumor. Post-radiation, you test the EB virus, sometimes the level goes up even before you can see the tumor because the tumor is growing inside. So this has been used to detect recurrences. But once you see that, then you do MRI, the tumor is probably too big. So we hope that we can get the tumors when they are small. So I actually I tested the EBV DNA in about 28 patients that I did the resection. So these are tumors that are really small tumors, are resected, but the Epstein-Barr virus DNA copies are only elevated in 2/3. Only 67% have elevated copies. Even though I have the tumor in my hand, only 67% patients, the DNA copies were elevated. But if they're elevated, after the resection, you check on day 7, the DNA copies will drop to 0 if it's curative resection. So in a way, the DNA copies reflects the tumor, probably the tumor volume. Maybe with radiation, with all the fibrosis, scarring, the cell dies, but the EB virus are not released into the blood. That may be another factor. Maybe the tests that we are able to detect the DNA may not be sensitive enough. So I don't know, but currently, its sensitivity in detecting small tumors that are resectable is roughly 6-7%. That's our experience.
We are a bit after schedule, but we started a bit late, so I would like to conclude with a last question, which is very simple-minded surgical question. It is follow-up with your presentation. If after radiochemotherapy we have a complete response locally and in the neck, if you have an N2 or N3 neck, there is no lymph node enlargement on CT or MR, what would you do? Do a neck dissection, wait and see, something else?
If all the tumor disappeared, the patient is cured. So I don't do anything. I just follow up the patient. I'm happy, the patient is happy.
Okay, thank you.
Maybe nowadays I check if the patient's worried, then I check Epstein-Barr virus DNA copies. This test costs about $100 in Hong Kong. So you can't do it every day. You do it once every few months, you do one. The patient can afford it.
Well, there's some data on electively operating on these patients in head and neck cancer of the non-nasopharynx variety, but even that is controversial. Many people will just continue to follow in the absence of any radiologic evidence of disease. But in particular for nasopharynx cancer, I would hesitate to operate on somebody who's had a complete response.
Wait and see then.
Wait and see.
You know, I'd just like to add to the idea of planned neck dissection and incorporating that back with the potential role for induction chemotherapy, is you can get a really great biological readout of the tumors with induction chemotherapy. And one of the questions that we're interested in is in patients who have very advanced nodal disease with excellent responses to induction chemotherapy, do those patients need a planned neck dissection? So in our N3 nasopharynx patients, we will consider a planned neck dissection where the decision is made on a patient-by-patient basis. But hopefully at some point in the future, we'll have more information on the biology of the tumor based on their response to treatment that can help guide those surgical decisions.
Mm-hmm. Dr. Bradley?
I would agree from my limited exposure, and I emphasize limited exposure with nasopharynx because we don't see that much of it. I would tend to treat the patient expectantly and really see, but we have available MR so you could follow up the patient if you needed, if they felt that there was something happening. Resorting to PET scan, we can get PET scans on selected patients, and it's really a matter of, and what are you going to do? My experience with PET scanning is there's still a lot of false positives and a lot of false negatives. So I would tend to rely on a combination of MR PET scan and the patient and what the patient would like. If the patient wants a neck dissection, then I would do a neck dissection. But William, of course, tells me I should do a radical neck dissection in nasopharynx neck metastasis. The question then is the morbidity. So you have an element of what you actually do.
But you do the neck only when the lymph node comes up.
Yeah,
if
sure.
It's clinical N0 neck, don't do it.
Then I would close this session with a small poll. Given the information we have discussed here last, how many of you would perform planned neck dissection? Hands up. How many would wait and see? Okay. Seems that we were rather correct in our discussion then. I would like to thank the audience, the panel, and the organizers for the possibility to coming here. Thank you.
Thank you very much.